Welcome to the fifth personalized surgery podcast. In this podcast, we try to bring renowned surgeons across the globe and learn from them how they use personalized surgery in their practice. Today, we are incredibly proud to have Dr. Vijay Bose from Chennai. Dr. Bose is a hip surgeon with 30 years of orthopedic experience with more than 2,000 surgeries done. And Dr. Bose has pioneered hip resurfacing as well as is also pioneered revision hip replacement surgeries. Dr. Bose finished his MBBS from Madras Medical College and then has done his FRCS from University of Liverpool, UK. He's also an author of one of the best-selling books, UHC, Universal Health Code. I have had a chance to read half of it, and it's really amazing. So, welcome, Dr. Bose, to the Personalized Surgery podcast. Yeah. So, one of the maybe we'll jump into the questions. When we talk about hip revision, what are some of the reasons these hip replacement implants fail? Is it really the implants that the surgeon use? Is it the fixation the way they do? Is it the alignment? Is it the surgeon? What is it?
Well, actually, it's a combination of various things. So earlier, the wear of the implants was a problem. So when we had the traditional poly, or as we call it, the conventional poly, that had a lifespan of only about 10-15 years. So the day that you do, you know that in 10-15 years, you're going to face a revision down the line. But luckily, over the last maybe 10-15 years, we now have much better bearings, especially the cross-link poly. And that gives us a much longer bandwidth. So we're talking now at least 30 years. So that problem has been solved to a large extent, but still there are a lot of patients who had the old implants earlier. So that we are now seeing a crop of those in the earlier stage. But now the primary reason is two things. One is that it has not been done well, especially in Asia and countries like India, where the training of surgeons is not uniform all the way around. And then there are surgeons who are not well trained. When they do this, then we see a lot of these complications now. And the second thing is infections. Infections again is a big problem, and we have to be cognizant of that. That is the second thing. The third thing, of course, is that Asian bone itself is very small, and therefore some of these implants that are made for the Western population, Caucasian population, doesn't seem to fit, and then also that gives rise to a series of problems that we see in the hip, which we have to sort out during revision surgery.
Yeah, when you mentioned about the training and not done well in the first place, is it primarily the non-cemented ones or is it the cemented one? Is there any typical trend that you see in these revision cases?
Not really. It occurs in both, but as a general rule of thumb, the dominant mode of doing it is non-cemented in India for whatever reason. And so we see more just because the numbers are more. We see also in cemented, but I don't think that plays a part in the mechanism of failure.
Right. And then when you say there's more infection as well, is it more to do with the surgical environment typically, or is it to do with the patient's ability or their immunity? What is it that is a more prone for the?
So now we know that the patient's factors play a very crucial role in infection. And the more that we understand the microbiome and things like that, we feel that the patient factors are the predominant. But this is common all over the world. It's not exclusive to India. But what is more exclusive to India is that the standards of OR, of course, also not as it could be.
Right.
So we're talking about metros, and then we go down to tier 2, tier 3, and then of course it falls,
right.
And therefore it has a say on the infection rates. Yeah.
Okay. Now, when these primary surgeries are happening, when we look at preoperative planning and planning using, say, X-ray or CT scans, do you feel that there is a role of preoperative planning, and any impact of that related to the revision?
Absolutely, yeah. So as a general rule, the more complex the surgery is, the more should be your pre-op planning. So that's the rule of thumb that we have. So obviously all revisions are complex surgeries. So earlier it used to be based on X-rays and templating. Now of course we have moved to CT scans, and we also do 3D printed models for us to plan and get a three-dimensional grasp of what's happening. And the more the complex situation is complex, the more we need to spend time.
Yeah.
And the CT also has to be segmented for us to get a really 3D concept of the whole thing, so that we can plan for the appropriate revision. I think with all these modern tools that we have now, planning is absolutely crucial.
Awesome. Great. So in the division, when we look at, say, revision surgeries and the type of deformities like 2B, 3A, 3B, pelvic discontinuity and all, there are off-the-shelf solutions available from multiple organizations, right? There are multiple companies who have like off-the-shelf solutions specifically for revision here. And then there's also an alternative where you can do a customized solution. So maybe if you can share, like, how would you compare, and what are the advantages of both of the systems?
Right. Okay. So the general rule, I don't think is as a competition. I think both will always coexist forever. So the obviously off-the-shelf solution is made for very common defects that we see commonly, because we are going to manufacture so many and then keep in your OR.
Yeah.
It needs to fit a certain number of people. That's how economics works. But if you have a peculiar situation in which it doesn't fit, then that's where the role of custom implants come into play. In the hip surgery, it works both for custom augments as well as more like the whole device being customized. So now we call it as FTL cup. But so both will always coexist. So when this stops, that starts. That's how I look at it. When you find that a custom or off-the-shelf option does not work, then we need to move into a custom solution.
Yeah.
One other factor I want to add is, especially for Asian, like the point I referred to, because we have small bones, and most of these off-the-shelf solution that we have is made for the Caucasian population, Caucasian anatomy, and therefore it doesn't fit us. So the role of doing something custom in India and in non-Western countries becomes even more important, I think.
Yeah, interesting. So you mentioned about the FDL cup. There's different terminologies, right? There's one that in revision they call it the cup cage construct, right? Which was sort of the traditional way of how it was done before. Then there is another term they use is a triflange, right? And then there is an FTL cup, which is the third one. Maybe if you can share a little bit about the difference between these three, it would help.
Sure. So the first thing that we refer to is the cup cage construct. That is very typically off-the-shelf solution to a very complex problem, the pelvic discontinuity, which is type 4, or the most complex ones that we see. That basically means that the upper hemisphere of your socket or your pelvis and the inferior hemisphere are disconnected, and both are moving independently. So we need something to bridge that. So they devised this cup cage construct in Mayo Clinic in the US. That's off the shelf. So that works well, but again, it has been designed with the Western anatomy, so it doesn't fit our populations. In fact, it's very, very exceptional to see an Indian or an Asian patient whom we can apply that concept, because it just doesn't seem to fit us. So that's the number one. So cup cage concept basically means that you put a big cup inside, over which you put a cage to protect your cup till it osteointegrate. That's what it means. Now, so the other solution that was developed internationally was the triflange cup, which basically was developed in Europe, where we had 3 big flanges which went into the ilium, the pubis, and the ischium, and that worked well. But one important thing, drawback that the Western countries had, was the turnover time was very huge. Usually, it was in the region of 8 to 10 weeks, which made which unpractical, and therefore the cup cage construct was used most of the time. This being used occasionally. Now, coming to the Asian population, the local situation that we have here, we found that also the cup cage concept was just too big. Even we found that the triflange cup was very big. We don't have space for 3 flanges, so we modified it. Thanks to there are a lot of engineering support from a lot of people, and we were able to manage it to the FTL cup. This means it's a flanged triaxial locking cup. So it's got 1 or 2, rarely it'll have 3 flanges, but so it'll have, depending on the size, but it'll be locked in all the 3 directions. So this was an excellent substitute for the triflange cup that seems to work very well in the Asian context.
Yeah, so when you say that it's a flange triaxial locking, how do you do all the 3 directional locking if there are no 3 flanges available in this cup? Maybe if you can share.
So the flanges is, when you have a lot of bone, you can make a flange sit on the bone, but we don't have flange, then we have to get locking screws. although there's no flange, we get long locking screws, and that sort of serves the purpose of a flange. So if there is a space, usually on the ilium or the superior side, you will get a lot of space, so we can use a flange on that side. Sometimes we use it on the ischium, sometimes on the pubis, but rarely you will have all three. So whatever is available, we use. Rest we substitute by long locking screws. And because it's custom, we are able to target that patient's bone where the bone stock is, and therefore it works as a substitute for a traditional flange implant.
When you say that, the screws can go long locking screws in all three directions, especially where the bone stock is. Like when you are designing or when you are working with the engineers on designing these, what are some of the key aspects you look for in the design? If you can share more on that.
Yeah, so the whole idea of this custom implant is we want to exploit the bone stock that's available. There's no point having bone stock that you're not using. So whatever is the available bone stock, we try to exploit what we have and harness that. So thanks to custom design, then we can actually target those areas where we can get long locking screws, and therefore we find that the direction of the screws are very important. And you'll find that in Indian patients, the columns are very small, so we have to have very precision to go on the columns. And because it is custom, it's also safe. We don't go across any important structure. So therefore, the planning is crucial, and along with the engineers, we keep refining the implant, the first design, second design, and then we are able to harness all the bone stock that's available.
Yeah. So now, when we are in the surgery with this kind of custom implants, we've also heard that custom implants, there is a challenge of finding a home position, right? And how do you address this for someone who's, say, just starting to do these kind of surgeries? What are some of the key nuances that help find this home accurately and quickly?
Right. So firstly, what I want to cover is that this has been a learning process for us. And when we started doing it about 3-4 years ago, and what we are doing now is a world apart, we have refined it. So the message I want to give is that, suppose if you have somebody to manufacture a cup as the first one, your design will not be very refined, because it's been a learning process and we have been refining and all that. So as we get more and more experience, our implants and the precision gets better and better. But one thing we learned is that when you come to large custom implants, you will never get 100% fit on it. So we have integrated some principles. So we are given some allowance. You can have a 1 or 2 degrees or 1 or 2 millimeters shift, but still it will work very well. So the tolerance is very important, and we built in tolerance into the modern implants now, so that even if you are off by 1 degree or 1 millimeter, it will still work. That's a very important thing. Second thing is, we now integrated what is known as practice. So this is a classical one that we have like that. So we have a bone model as well like this, and then we would during the surgery, this we call as, actually it gives you a 4-dimensional concept. So we have the 3 dimensions of what we think. So we keep this is a plastic implant, plastic model. Both are sterile. This is the OR, and then we keep this as how the real implant would go, and then we practice. So the patient is here. We are now seeing the patient. We are keeping the bone model as how you're seeing the actual bone. And then we are practicing the drilling on the bone model just beside the patient. And this tells us, and I can flip it and see, is there any important structure here, where my screw is holding, how long the screw will go, like that. And that gives a fantastic, perception for the surgeon to execute that. And because the bigger the implant, the home run is going to be difficult. And so the bigger the implant, the more the need for this. And we sort of try and see if that's the best match and how we can get the best position, and then we go to the real implant on the patient. And because we just now have a muscle memory and a brain concept of how we are doing it, we are able to fit that into the real patient like that. And then also the drilling, also we have a fantastic muscle memory of where we're doing our direction of perception of depth, etc., and then we are able to execute that.
Interesting. So having having a prototype or having a model intraoperatively of both the implant as well as the real implant, so you're kind of practicing it before you're actually doing it inside the surgery. Absolutely. To kind of match and say, okay, this is how it is on the bone, on the model, and this is how we would like it, and that kind of reduces. What do you think is the reason why the home fit is there's while there is 1-2 millimeters space? Is it because of the soft tissue that small, call it like a you don't get like a always 100% press fit in all cases. Like, what do you think is the reason for
Well,
this?
the combination of reasons. One is the soft tissues, yeah. So
Mhm.
we don't give allowance to soft tissues, and because it's complex surgery and there are very vital structures nearby, we cannot remove all soft tissues like how you would. Sometimes we just cannot go near that area, danger territory. We just have to leave the soft tissue there. So that gives a little bit of a misfit. Second thing, of course, if the CT is not very precise and the cut slice is not very thin, then again that may be an error built into it. Yeah. The third thing is some bone is loose bone, friable bone, which of course the CT doesn't know. It just interprets as bone. And then we find that some bone, as you expose, just falls off. Some bone is removed. So that's again a mismatch. The three factors combine to give us some kind of a mismatch. And I think these, especially with relation to the large implants in the hip, one will have to build in some tolerance for to accommodate a little bit of mismatch and still be able to execute the surgery.
What do you think would be an impact of, let's say, that 1 or 2 degree off in the end? What may have been planned and what actually got executed. Maybe there is 1 degree off and 1 millimeter off.
I don't think it will have any impact at all because as we refined this FTL implant, we found that we need to have extra screws as well. So suppose one screw misses it, you have another option of screws. And two, we find that because we are practicing the model, we know that we are going to get a good screw purchase. So the screw length may change a little bit. You may have planned for a 55, you may end up with a 50, but that doesn't change anything because what you're talking about is in millimeters. The overall construct strength, I don't think it changes.
Awesome. When you mentioned that there is these dangerous structures, what are some of those structures, and how do you take care of them during these surgeries?
Well, the inside of the pelvis, of course, we have important, the viscera in the abdomen that we have organs, and we have the blood vessels. And any major blood vessels, if you injure on the other side of the pelvis, there's no way you can control it. And we need to flip the patient over, open the abdomen before you can. That may be too late. So we're always conscious about it. And this is a big advantage of custom implants over traditional off-the-shelf implants. Because off-the-shelf implants, you just play around during surgery and you fix it where you think and then you're drilling. But this is planned on the bone corridors. And because we have a plastic model to practice, we know exactly where we are. And if we're not there on the real patient, we know we are going somewhere wrong. Then we need to do some course correction and make sure. Because we have practiced, we know that we are on the bone and the custom is made for the bone corridors. This makes, I feel that the custom implants are a huge step better as regards patient safety. I really feel that.
Awesome. So while there's minor changes, overall the safety is significantly higher because you really cannot go too wrong, right? Or all wrong.
That's well put. Yeah, you cannot go too wrong. He'll tell you that it's too wrong, and sometimes if you have only off-the-shelf implants, you have to make it fit. So you're pushing the boundary more and more. But this we know it fits. We have practiced it. We know it's going to fit. So we can do a good job. But there, when you find there's no other option, we just have to take that risk. But here we don't have to take that risk.
Amazing. So now some of these patients who have 3A 3B type or pelvic discontinuity, their muscles, other than the bone, their muscles are not always as strong. And there are literature that talks about dislocations in these kind of situations, post-operatively. So how do you really mitigate that risk of dislocation in these kind of revision cases?
So any major revision hip surgery comes with the risk of dislocation. No, going off from that. However, we do whatever is possible in our hands to mitigate that risk. So one thing is to use a dual mobility liner. So we can cement a dual mobility. After you put your FTL implant, then we put a dual mobility liner. And then that, of course, mitigates to a significant extent. Now, these days, more literature coming out that bigger heads, especially made out of ceramic, we find that our standard stems can accommodate bigger heads like 40 and 44. So just a question of making the poly for that, and then we put 40 and 44 heads where we can, and then that significantly mitigates. But there's no going away from the fact that any major, whenever the more major, the chance of dislocation will always be there.
Amazing. So, so dual mobility is reduces the risks. Large head, awesome. The other, some other tips you would like to give to these surgeons who are trying these implants for the first time. What are some of the things from your early days of learning that you would recommend to kind of utilize for these cases?
Yeah. So the first thing is actually pre-op planning. So we need to really, you need to spend some time on it and think all about it. And then maybe you can have a chat with the surgeon who has done lots of it. And then during the surgery, it's very important to practice during the surgery, actual practice that we call as 4-dimensional practice, because the patient is there and you're practicing just, and you're orienting everything to where the patient is. It's not just on a plastic model. You're the plastic model oriented to what exactly you're seeing on the, that gives you a different perception completely. So the surgeon has to practice, and then whenever, because we are now refined the implant over so many hundreds and hundreds of surgeries, you have to think that the implant is going to fit.
Mm-hmm.
And if something is not working, it's something that you are doing wrong, and you need to make some adjustments and fit. You shouldn't jump to the conclusion that you have an implant that's not fitting. It's most likely that what you are doing something wrong. Then again, you go back to the plastic model and then you make that fit. And if it's good that if you can have a surgeon who's already done one of this before with you as a proctor, that would still be better for a surgeon who is starting off.
So a little bit of a patience during the surgery, and then models that help along with some helping hand.
That's it. You cannot do too much of pre-op planning.
Yes.
There's no other way you can do. There's nothing like too much of it. So you need to spend time on that. Yeah.
Awesome. So where do you 10 years from now? Where we've made significant progress over the last 10 years. What used to happen before and what happened
before
now.
I forget that. Another very important part. The other thing is when you have a custom, off-the-shelf implant like a cup cage construct, you need to have a large amount of volume and experience to do that. You need a very significant volume to do such a thing. But a custom implant is not like that, because so a lot of these surgical steps that you have to do per-op has been taken out pre-op. A lot of things you're doing pre-op, and so it's just a question of putting it in and putting the screws inside, which every surgeon would do. So as regards experience, a much less experienced surgeon can do a custom implant. A very, very experienced surgeon has to do complex defects by using a cup cage construct or off the shelf. That's a very important point.
Interesting. Yeah. Because now in the intraoperatively, you have already reduced your risks, and once you find the home, you have the home and you can just put the screws and you know that you're not going to go wrong. While in the cup cage construct, you have a lot of these soft tissues and these dangerous vessels that you have to protect during these, could have a higher risk for...
The danger is one part of it. The other thing is your plan has to come only after you open the patient. When you are going to off-the-shelf implant, you open the patient and then only you are seeing what can I fit, and the planning itself starts that stage. But here, 80% is already done, and you know exactly what your plan is, and then it's just a question of execution. Whereas there, where am I going to put the cage? Where am I going to put the cup? Where I'm going to put the screws? Planning starts after opening. But here, the final 20 part that you're going to do, 20% you're going to do, 80 part is already done. So certainly it would help a surgeon who doesn't have large amounts of experience.
What about like cup alignment, like version inclination and all? So when you do these kind of, say, FTL cups and custom, what do you generally recommend to have as an inclination and version? Do you go with patient's other side's native and then exactly try to match it? Or do you say that, leave that to me intraoperatively? Like, what's your...
Right. So my take on that is now we have what's known as this functional alignment. So we now, even for primary cases, we use what's known as functional. So functional alignment is a good place to go for a general. So suppose you have 100 patients and you want to put the same value in every patient, that's what is functional alignment. Personalized is, of course, we do that. So personalized works very well for primary surgeries, but whether it's the equivalent of the mechanical alignment in the knee. So they've been doing it for 3 decades. So mechanical alignment is not a bad place to be, but there can be little better places by doing customization. But in very complex cases, your aims are completely different. The aim is to make the patient walk. It must be so. This customization regarding implant position doesn't come into play at all. So you must have a set target post, and that must be executed for all patients. And that is a functional version and inclination that must be executed.
So intraoperatively, using a cemented liner, you are changing or you are placing your version inclination according to the patient's soft. Is that maybe if you can elaborate a little more, like how would you define that version inclination for, say, an FTL cup, and what are some of the aspects that you look at?
Well, because it's a custom implant, it comes built in with a certain amount of inclination based on that. It comes with that, yeah. But again, like per-op, you can do a little bit of customization. So I would aim for about 38-40 degrees of cup inclination and about 20-25 degrees of anteversion.
Mm-hmm.
That's a good place to be in all patients, because you have to take the spinopelvis also. That's why it becomes functional. The spine is also taken into consideration. So if you have gone up a little bit, then you can use the simulated poly liner to change what you are. But unlike off the shelf, where you will be completely off, and we need to really dial in much more. Here it will be only very subtle, but we can use an advantage. The other thing that we can use are the hooded liners. So you can use hooded liners, and that also will give you some some play to change to where you want the functional version and inclination.
Interesting. Awesome. Great. So coming back to the future now, and say, where we were 10 years ago, where we are today, where do you see revision hip surgeries 10 years, 20 years from now? Like, what's your vision?
Yeah, so now with the recent AI, things are so much of a flux, and we really don't know. Everything is changing at a rapid pace, so it may be unrecognizable from what they're doing today, but this seems to be the state of art. And what is so fortunate is that we are able to do it on a relatively economically for our patients. So another important point that I want to make is that the cost wise, we are cost neutral or even slightly lower than off the shelf implants that we are able to get. That is a huge bonus. So it's not a question of doing only in the big corporate hospitals. This type of things must reach everyone, and that's a very fantastic thing in my opinion, that we are able to. We have a big software strength in our country. We also have low manufacturing costs, which really helped us, and I think that's the advantage that we have here. And the most important point that I want to give is that, as a rule of thumb, if in the Western world it takes 10 weeks to do, we do it in 10 days. So it's weeks to days is the ratio. So something takes 4 weeks, we do it in 4 days. So that is really a game changer. And the reason why many Western countries do not adopt it as extensively as we have is because of this lag period. They're just not able to cope with that. Now, I suspect this lag period is also going to come down even further. And so it'll be like, you can have it next week for your surgery. And that, I think, is something fantastic. And I think we have to lead the world because of our strength in software and in manufacturing, that we have to lead the world in this type of technology.
Yeah, so AI is truly changing a lot of things, and definitely, the softwares will help accelerate some of these activities. So now, of course, while the manufacturing has to take its own time, your preoperative planning, a lot of these things can be, automated or semi-automated to really improve. And so you see that 10 years from now, it's going to be maybe few days, and you have your your implant, and you operate it and plan it within
or maybe the next day. Yeah, so
next
the next day you can have it. As things are going, we really have that. Yeah.
Other question is, like, when is FTL cup, would that work for all types of cases? When you have even more complexities, are there any other things you look for?
Right. So as I told you earlier, it's been a journey, and we've been refining, learning, and as we are going, developing so many things. So one thing that we found was very large defects. We find to make a home run, to make a very large device, there are a lot of defects both in the the upper hemisphere and the lower one. It's difficult. So we have developed 3 different strategies to counter that. The first thing is what we call as a 2-part D-link cup. So we put one custom implant on the upper hemisphere and one on the lower hemisphere, and both are unitized with cement, and therefore the implant size becomes half. As I told you earlier, the larger the size, the more difficult it's going to get a home run. So basically the implant becomes half the size, and that seems to work very well. And then that's one point. Then we have this inferior augment. This is an example actually of an inferior augment. So we talk about this superior augments, where it's well known. So now we have, because it's custom made, we can have specialized augments for the ischium and the pubis. So we put this augment inside, and then we are able to put this screws, and therefore this would work as well. So this is the second one. We have inferior augments for that. The third thing, of course, is like the putting a long screw that goes up to the sacrum. This is well been done, experience in oncology. A lot of bone resections, they will put that long screw. But here also we can put long screws going up to the sacroiliac joint. And actually, with custom implants, you can get bite in the sacroiliac joint itself. The sacrum itself. Sacrum has got very good bone. So when the ilium, there's a lot of bone loss in the ilium, and the next step that you have is the sacrum. So we can get long screws that goes into the sacrum. So that's again an extended mode fixation. So these three are we call as extended mode fixations. The delinked cup, we can have sacral fixation, or we can have inferior augments as well, or you can have one superior augment and an inferior augment, and we can. So these are the three modes which you have developed that will handle much more complex cases.
So when you put these long screws in the sacroiliac joint or near that with the column, are locking screws versus say a peg? What are some of the advantages of say screws or peg? Like what would be your
both would serve different purposes. So if there's just lack of bone stock, then you would find that long screws, locking screws up to the sacroiliac joint involving the sacral ala itself is a good idea. But if you were doing something in which there is especially loss of one anterior hemipelvis is lost, then we need to a long sort of a bolt or a peg that goes up to the would be a better idea. So in different situations this would work. In different situations the other thing will also work.
So this tell us a little bit more about this CCD augment and what it stands for, and in what situations you use these what we call it as a Bose CCD augment, and in when you use it as an FTL cup and these solutions.
Right. So this is a very typical augment that is available off the shelf. So it comes in a few sizes, but of course you are very restricted in that to use. So this again is made for the Caucasian anatomy, for the Western patients. So many of them are too high profile for our patients. And the second thing is the bone stock, the entire bone stock is also very small. So many times when we, in fact, my own experience, I have opened one or two, sometimes three augments I've opened, and then I find that I'm not able to fit anything inside. So they've gone waste. Whereas this is a CCD augment, it doesn't work like that because it's meant for the patient. So it will fit exactly because sizes are small for that particular patient, will fit very well. Now, because there's a lack of bone stock, now what we now do is we try and get screws from superior to inferior along the columns. The columns in revisions will be very narrow, so unless you have a custom augment, you cannot get that. So we developed this concept of a CCD, means custom columnar docking, or we put long locking screws along the column because we don't have enough bone stock, and therefore it's like a anchor. It anchors the three dimensions. So in any place that you want the augment, we can get long locking screws coming from superior to inferior, which is never possible in off-the-shelf augment, and therefore we develop the CCD augment. So patients who are smaller in size, especially, and in one you may need this off-the-shelf augment may not fix. Another very important point is when you have a defect in the walls, anterior posterior wall, superior defect is okay, off-the-shelf will work well. But if you have defects extending down the posterior or the anterior wall, then your off-the-shelf augments will not work. Then you need to have a custom augment where we get fixated superiorly, but we'll have like a tail extending down. So these are the two indications in which the off-the-shelf augments won't work, and we need to go for a CCD augment.
So any of the columns, either anterior or posterior column, if that has an issue in those revision cases, then your off-the-shelf may not be the best choice, and custom may be a better choice. But assuming that one of the column is intact, right? So when you have both the columns not intact, then what do you do?
We have to go to FTL cup.
Then you go to
FTL cup. So as a general principle, when you have a standard, highly porous cup these days are very good. So you can get a standard highly porous cup for the simple reason they have documented history of having a long lasting. So if you want to use that cup, that's good. So we need to get the third point, as we call it. So that's the reason why. So if we have only a superior defect, then off-the-shelf augment like this would work very well. But if you have a defect that's extending both either anteriorly or posteriorly, then we need to have a custom augment to solve that particular situation.
So thank you, Dr. Bose. We really appreciate your time and giving us this opportunity for this personalized surgery podcast. It's really an honor to have a surgeon, an orthopedic surgeon in our podcast. So one of the things about Dr. Bose is that if an orthopedic surgeons have their loved ones to be operated for some reason, they all come to Dr. Bose. So it's really an honor to have you in our podcast and giving us all these complex hip surgery insights for our viewers. Thank you. Really appreciate your time.
Thanks, Ketan. I must say that, as surgeons, of course, we like to do many things, but we have to have an engineering strength like yourself and Jajal Medical, where we can leverage that strength. Yeah, you can have a lot of ideas, but you have to put it into practice. You must bring it finally to the benefit of the patient. And I think you have played a very important role in that. So I can't thank you enough. Thank you.
Thank you, sir. Thank you, sir.